Hi, this is Dr. Akhtar. Today topic is interstitial keratitis. It is inflammation of the corneal stroma and it is without primary involvement of the epithelium or endothelium. So it is inflammation of the corneal stroma. In most cases the inflammation is thought to be immune mediated process triggered by appropriate antigen. The term interstitial keratitis is most commonly used to refer the late appearance of feathery mid-stromal scarring with goose twizzles. So it is the late appearance of the disease. The former is typically an incidental finding. Syphilitic IK is the archetype. But the relative frequency of causes varies markedly by geographic region. There is a wide range of causes, including herpes simplex, varicella zoster, and other viral infections, tuberculosis, Lyme disease, and other infections. Parasitic disease are an important cause in areas where these are endemic. Sarcoidosis, Cogan syndrome, and non-infectious inflammatory conditions. So it may be infectious and it may be non-infectious. In infectious, the syphilis is the most common. The interstitial keratitis, which is caused by syphilis, the origin is usually the result of congenital infection, though acquired syphilis can also be responsible. All patients with acute IK or with incidental discovery of its chronic appearance should be investigated to exclude congenital and acquired syphilis. So syphilis should be investigated irrespective of the presence of systemic clinical signs. There are numerous reported cases of congenital syphilis being identified for the first time in later life on this basis. Congenital syphilis infection of the fetus can occur across the placenta, leading to stillbirth, subclinical infection, and a range of clinical features. Early systemic features. It include failure to thrive, maculopapular rash, mucosal ulcers, characteristic fissures around the lips called ruggeds, and a range of organ involvement. The late systemic signs include sensory neural deafness, saddle-shaped nasal deformity, Sabry tibia, bulldog jaw, in which there is mandibular prominence due to maxillary underdevelopment, Hutchinson teeth, which are notched, small, widely spaced teeth, and Clayton joints, in which there is painless effusions in large joints, especially the knees. Ocular features. Ocular features include uveitis, IK dislocated or subluxated lens, cataract, optic atrophy, salt and pepper pigmentary retinopathy, and Argyll-Robertson pupil. This is salt and pepper pigmentary retinopathy. Now presentation of syphilitic interstitial keratitis. Following congenital syphilitic infection, it occurs between 5 and 25 years. Initial symptoms are those of anterior acute uveitis. There is severe blurring. Involvement is bilateral in 80%, although usually not simultaneous. In acquired disease, IK is less common and usually unilateral, typically occurring years after the age which the disease was contracted, although it can occur as a part of the syndrome of family infection. Now the signs. There is profoundly decreased visual acuity in the active stage. Limbitis associated with deep stromal vascularization, with cellular infiltration, clouding that may obscure the still perfused vessels to give characteristic pinkish salmon patch appearance. This is salmon patch appearance. Granulomatous anterior uveitis. After several months, the cornea begins to clear. The vessel become non-perfused, called ghost vessels. If the cornea later becomes inflamed, the vessels may refill with blood and may rarely bleed into the stroma. Here you can see the healed stage is characterized by ghost vessels, feathery deep stromal scarring, sometimes thinning astigmatism and band keratopathy. Treatment of active syphilitic interstitial keratitis is with topical steroids and cycloplegics, as well as immediate systemic therapy under a care of genitourinary or infectious disease specialist. So this was all about interstitial keratitis, in which there is salt and pepper retinopathy, in which there is saddle shaped nasal deformity in syphilis, there is seborrheic tibia, Hutchinson teeth, and there is salmon patch, deep stromal vascularization, clouding, ghost vessels, intrastromal hemorrhage from reperfusion, feathery scarring, no tracks of ghost vessels. Next is Cogan syndrome. It is a rare systemic autoimmune vasculitis characterized by intraocular inflammation and vestibuloauditory dysfunction, particularly neurosensory, developing within months of each other. The disease primarily occurs in young adults, with both sexes affected equally. Children can also be affected. Systemic features occur in 30%, include multi-system vasculitis that can be life-threatening. Multi-specialty management is vital. Diagnosis. Ocular and inner ear symptoms are often separated by a substantial period. The acute phase may last from months to years. Sussex syndrome is retinocochleocerebral vasculopathy. Should be considered in differential diagnosis. The vestibuloauditory dysfunction. The symptoms are deafness, tinnitus, vertigo. The ocular symptoms are redness. Pain, photophobia, blurred vision. The ocular signs, there are corneal involvement commences with faint bilateral peripheral anterior stromal opacities. Deeper opacities, corneal neovascularization, mid-stromal vascular loops then ensue, often with central progression. Here you can see mid-stromal vascular loops, and there is deeper opacities, there is central progression. Uveitis, keratitis, retinal vasculitis may develop. Investigations are erythrocyte sedimentation rate, C-reactive protein may be elevated and the white cell count raised. Antibodies to inner ear antigen may be detectable. MRI may show inner ear and other abnormalities. The treatment is with topical steroids for keratitis, with additional measures as appropriate. Systemic steroids for vestibuloauditory symptoms, 1 to 2 gram per kg prednisolone to prevent hearing loss. Immunosuppressive therapy may also be required. Systemic steroids may also be required for scleritis, retinal vasculitis. So this was all about the Cogan syndrome, in which there is peripheral and central scarring, and there is interstitial keratitis, and vestibuloauditory symptoms as well as ocular symptoms and signs. Protozoa keratitis, in which the first one is acanthamoeba. Acanthamoeba are ubiquitous free-living protozoa commonly found in the soil, fresh or brackish water, upper respiratory tract. The cystic form is highly resilient. Under appropriate environmental conditions, cysts turn into tropozoites with tissue penetration and destruction. In developed countries, acanthamoeba keratitis is most frequently associated with contact lens wearers, especially if the tap water is used for rinsing. Diagnosis. The condition is often diagnosed initially as herpes simplex keratitis. With more advanced signs, the condition should be distinguished from fungal keratitis. There is blurred vision, discomfort, pain is often severe. Pain is severe and characteristically disproportionate to the clinical signs. The signs are in early disease, epithelial surface is irregular and grayish. Epithelial pseudodendrites resembling herpetic lesions may form. Limbitis with diffuse or focal anterior stromal opacities. Focal anterior stromal opacities. Characteristic perineural infiltrates. Radial keratoneuritis, also known as radial keratoneuritis. They are seen during the first few weeks. They are virtually pathognomonic. For acanthamoeba, gradual enlargement, coalescence of infiltrates to form a ring abscess. This is typical. Scleritis may develop generally reactive rather than extension of infection. This is also ring abscess. Slowly progressive stromal opacities, pacification and vascularization, and there is loss at the last corneal melting may occur at any stage when there is stromal disease. The melt often develops at the periphery area of infiltrate. So there is Epithelial involvement, there is stromal opacities, perineuritis, ring abscess and melting. Investigation: staining of this corneal scraping. Usually periodic acid skip or chalcofluor white, which is a fluorescent dye with affinity for amoebic cyst and fungi. Gram and Giamsa stain may also demonstrate cyst. Culture: non-nutrient agar seeded with dead E. coli which trophozoite consumes. Trophozoite consume E. coli. Other investigations include immunohistochemistry, PCR, in-wow confocal microscopy, corneal biopsy for diagnosis. Treatment: it is important to maintain a high index of suspicion for acanthamoeba in any patient with a limited response to antibacterial therapy. The outcome is very much better if treatment is started early. Debridement of involved epithelium is believed to be helpful. It may facilitate eye drop penetration. Topical amoebicides, acanthamoeba cysts are resistant to most antimicrobial agents. Although successful outcomes have been reported using a variety of topical preparations, it is likely that some of these are active only against trophozoite stage. Polyhexamethylene biguanide (PHMB) 0.02%, chlorhexidine 0.02% kill trophozoites and are cysticidal. Hexamidine, propamidine, also known as brulene, has greater activity. Uriconazole and other azole antifungal may be effective. Optimal regimen has not been established. Samples include PHMB as therapy with chlorhexidine. Either of these in combination with hexamidine, propamidine. Installation is hourly at first and gradually reduced. Clear response may take 2 weeks. Simultaneous antibacterial treatment for co-infection may be considered. The clinical picture suggests this. Relapses are common. As treatment is tapered, it may be necessary to continue treatment for many months. Topical steroids should be avoided if possible. Although low-dose therapy delayed for at least 2 weeks, after starting anti-amoebic treatment may be useful for persistent inflammation. Besides, treatment should be continued in concert with and for several weeks after steroids. Pain control is with oral non-steroidal anti-inflammatory agents. Therapeutic keratoplasty may be necessary for resistant cases, including perforation. Late scarring may also require penetrating keratoplasty. So, acanthamoeba infection of the cornea results in pain that is often severe and disproportionate to the clinical signs. Thank you so much.